Okay, thank you very much for the nice introduction, and thank you for nice moderating. Uh, Before I start, I want to thank all the societies participating to arrange this webinar for you. Thank you first of all for EMA, Emirates Medical Association, Emirates Pharmacy Society, Emirates Society for Mental Health, and Emirates Family Medicine Society. Uh, and as I said in the beginning, MedTalk is aim to bring pharmacy and physician talk together and talk medication together, and this will be the first session. I joined ERADA Center for Treatment and Rehab around 1 year, and I want to introduce for you what I learned, and I will focus on pharmacotherapy management of opioid disorder. Uh, Also, I want to thank Marifa. They are our organizer. And also, I want to thank Pfizer and Stada. Pfizer is the main sponsor and the supporting company Stada. This is the objective. I'll try to finish within 20 minutes, and I'll pass some slides to be within the time. So this is the outline. So here, some example of substance of abuse disorder: alcohol, opioids, tobacco, benzodiazepines, stimulants like amphetamine, cannabis, others like pregabalin and gabapentin. Those with red color and with the star, those medication has evidence-based pharmacotherapy. There's a medication used to treat them. But the other one with the black color, there is no yet well established. There is some trial, but there is no well established medication. I have some MCQ question. So, which of the following substance does not have evidence-based pharmacotherapy available? Please, you can write in the chat box. Or you can type in the chat box the answer. I'll give you 5 seconds. Maybe you are using Q&A. Yeah, okay. Yes. So we will see the answer at the end in the Kahoot. Most of you are correct. So alcohol has, opioid has, tobacco has, but cannabinoids not yet. So what is substance use disorder? Addiction or substance use disorder is a chronic relapsing disease. This is the most important message I want you to take with you today. Addiction is a disease, and it's a chronic disease. It's not a habit. Patient, if he is already an addict, he cannot get rid from the addiction without help with a multidisciplinary team, including psychiatrist, and he need a rehab specialist, and to be linked to a program. So it is disease, not it's a habit. It's considered brain disorder since it involves function change to brain circuit, involve reward system and stress and self-control, and those change may last long time after a person has stopped taking the drug. For diagnosis of this disease, we have a diagnostic and statistical disorder version 5, which is used for diagnosis. So again, we need this addiction need to be diagnosed as a disease. So true or false, addiction or substance use disorder is a chronic relapsing disease. It's not only chronic, it's also relapsing disease. So true or false? Yes, true. So substance use disorder definition according to diagnostic criteria, we have here 11 criteria. If we found 2 criteria in the last 12-month period, we can consider this patient addict. What's this? I will give you example of this. The substance is used greater amount or over longer period than intended. Persistent desire to use, unsuccessful effort to control the use. Significant time spent obtaining, using, or recovering from substance use. Normal people will think what they will do today, but the addicted person, he will think how to get the substance. Strong desire to use substance, craving. بالعربي بيسموه الشوق. Recurrent use with significant impact or fulfilling school, home, or work obligation. He will absent from work. Continue using despite serial and interpersonal problems. He have problem with his family, but he will continue using the substance. Giving up, then now he will start isolating himself. So giving up social, occupational, recreational activities because of substance use. Recurrent use in a situation that is physically hazardous. Maybe he's driving this and they will lead to accident, etc. Continue use of despite knowledge of persistent or recurrent physical or psychological problem related to substance use. And last two is tolerance and withdrawal. So tolerance needs to greater amount of the substance to achieve intoxication or even the effect. Withdrawal, characterized withdrawal syndrome for individual substance. Each substance has its own withdrawal symptoms. Another similar substance is used if applicable to relieve or avoid withdrawal symptoms. So if we found two of these, we can diagnose it as addiction. And here some specifier, early remission, full criteria for substance disorder met in the past, and no criteria have been for at least 3 months, but no longer than 12 months. If we already reach to 12 months, it's sustainable remission. On maintenance, if the patient is taking maintenance, and thank you for Professor Amani, she helped me to make you familiar with such medication like methadone and naltrexone and buprenorphine. This is medication used for as a maintenance. In control environment like ERADA center, our center may be used if individual has limited access to substance based on environmental control. As we said, there is a diagnosis, and like any other disease, there is severity, and this is based on the symptoms. If we found 0 to 1 symptoms, so there is no diagnosis because we said at least 2. 2 to 3, it's mild. 4 to 5, it's moderate. And more than 6, it's severe. So the effect of the drug on the brain consists of neuron, which send and receive signal via neurotransmitter. Some drug, when taken, can activate these neurons simply because their structure similar to the natural neurotransmitter. But those drugs activate the neuron, they do not activate them in a natural way, or they release natural substance, but large amount that is considered abnormal. Example is amphetamine. So both type of the drugs amplify and disrupt the normal communication in the brain. So in summary, again, the effect it's on the brain, and I don't want to take you to all this name on centers in the brain because it will take time, but it will affect the VTA and other neuron therapy circle, and will affect the reward system. Some risk factor, it is a multifactorial, it's biosocial and psychosocial risk factor. Genetic play a role. For example, in alcohol, up to 60% peer pressure from friends, sibling, and member of certain social group. Advertisement, especially with alcohol and tobacco, and some psychiatric disease. Core component of treatment, either stage intervention or motivational intervention. For example, in motivational intervention, patients are encouraged to develop goals, recognize readiness to change. He needs to show that he's willing to change. Help individual develop hope and greater understanding of illness. Counseling, cognitive behavior, group family, social support, intervention, long-term prospective recovery occur over month to year. So it needs a time. We need to treat patients for a long time to recover from such disease. Of course, there is a stigma associated with the disease, and we need to try to reduce this stigma by make people well aware this is a disease. It's not a habit. It's not, he cannot get from it without help. Opioid-related disorder, we have, opium, right? So from opium poppy, we call the scientific name Papaver somniferum. opioid alkaloid found in opium poppy like codeine and morphine, and opioid compound like has like action. Example is endogenous endorphins, heroin, and prescribed medication like fentanyl, hydroxycodone, and oxycodone. Uh, if the patient took over a dose, we call it opioid intoxication, and the criteria is construction of pupils or deletion of pupils, secondly to anoxia from severe overdose, along with one of or more of the following signs: drowsiness or coma, slurred speech, impaired attention or memory. Symptom not caused by, it should be not caused by general medical condition. Always we have to exclude this condition. Opioid withdrawal, it comes in different stage. The first stage in the within 72-hour physical symptoms at peak, like fever, body ache, diarrhea, insomnia, etc. After 1 week, physical symptoms start to lessen, reduce, and then the second week, psychiatry and emotional symptoms like depression and anxiety, irritability. That's why most of the patients who will be treated from opioid, they have to be on antidepressant and sleeping medication. This is the main class of medication for therapy. Sign of symptoms for opioid intoxication: shallow or shallow respiration, papillary meiosis, bradycardia. And for opioid withdrawal, we have here you can see list of withdrawal symptoms, including nausea, diarrhea, coughing, lacrimation, mydriasis, sweating, muscle twitching, piloerection, hair. It's hair will stands, yawing, and drug craving. Time-bound estimation depends on the pharmacokinetic of the drug and the half-life, and it peak occur between 36 to 72 hours. Withdrawal should be completed within 5 to 8 days. It depends on the half-life of the substance. So, what is the answer of this question? Opioid withdrawal symptoms include nausea, diarrhea, mydriasis, rhinorrhea, piloerection, yawing, and drug craving, all of the above. And the answer is yes. Most of you answer D, correct. Thank you. Treatment guideline for opioid-related disorder. For opioid intoxication, the antidote is naloxone, and is FDA approved for recommended in the ABA guidelines. So it's بيسموه باللغة العربية الترياق النوعي. Naloxone is full agonist, full antagonist. Opioid withdrawal or opioid use disorder, we need to give the patient maintenance therapy. First, for the withdrawal, methadone and buprenorphine, naloxone, which we call it Suboxone. It's a film under the mouth given, and this is for to avoid the withdrawal in the first 2 to 3 weeks. Then we will shift the patient to maintenance therapy. Switching methadone may be required if buprenorphine fail to prevent craving. See, there is some serious medical problem associated with intravenous opioid because they are most of the patients they will share the needles. So skin abscess, liver and kidney disease, endocarditis, and we notice in endocarditis, MRCA is one of the main organisms you have to be covering if you have treating endocarditis empirically for drug use disorder till it's proven elsewise. A pulmonary infection, TB, pneumonia, hepatitis B, C, very common. HIV, it's there, but not that much common. And if HIV not treated for long period of time, it may shift to AIDS. So according to different guidelines, the first line for treatment of opioid intoxication is, as we mentioned, naloxone for overdose. But for dependence, buprenorphine and methadone mostly. But and here even in American society, they also add naltrexone as the first line. And here you can see second line, clonidine. Naltrexone is in ABE, and here also slow release oral morphine, naltrexone, etc. So again, we have three drugs in the first line at least: buprenorphine, methadone, and naltrexone. So all of the following medication are used at the first line in the treatment of opioid dependence except. So what's the answer? Buprenorphine, methadone, clonidine, or naltrexone? Except one is second line. Three of them first line. What's the answer? Yes, thank you. Thank you, Rania. Thank you, Hazim. Perfect answer. Clonidine. Non-pharmacologic treatment, including motivational interviewing, cognitive behavior therapy, behavior therapy, contingency management, family therapy and counseling, psychoeducation, self-help group. The patient who's already recovered, they can help other people and guide them what they did for to be mutaafi. So this is the list of drug and the year of approved by FDA to be used for opioid dependence. Methadone, it's old one, 1950. Naltrexone, 1994. Long-acting depot naltrexone injection. It's actually very expensive. This injection around 7,000 dirham. 2010. Buprenorphine, the different dosage form, 2002. Livoxidine, 2018. And last new one, long-acting buprenorphine, 2018, which we are using in our formulary for treatment. So opioid intoxication, as we mentioned, naloxone is the opioid receptor antagonist, and it's the antidote. What's the antidote for opioid intoxication? And buprenorphine, naloxone, clonidine, naltrexone. Please don't confuse between naloxone and naltrexone. The answer is yes. Most of you answer correctly, mashallah. Very good. The antidote is naloxone, B. Opioid withdrawal and detoxification, we need to do some baseline assessment, vital signs, LFT, urine toxicology, to see if the patient taking any substance, physical exam, ECG, infectious disease, like we said, it's a risk factor. And in this graph, you can see the drug used for the treatment, either methadone, which is full agonist, although it is full agonist is used. The reason for that, because it have very long half-life. So the withdrawal will be less with this. So that's the criteria, make the methadone was good drug to be used because of long half-life. And we have buprenorphine, which is partial agonist. So it will not block all the receptors, it will block partially, but the affinity for buprenorphine is higher than morphine itself. So it will block the receptor. When the patient will take morphine, morphine will not act, so he will not feel the high. And last drug is naltrexone, which is antagonist, is used also for treatment as one option for pharmacotherapy treatment. So all which medication can be used for opioid dependent disorder: buprenorphine, methadone, naltrexone, or all of the above. Yes, yes. Thank you very much. Most of you, Muhammad, Anil, yeah, all you are correct. Good, good. Thank you very much. Appreciate all of the above. So methadone, we are not using in our center. Methadone, it needs daily giving in the center. That's why it's difficult. And it has also many side effects, including QT interval black box warning for QT prolongation. Especially, it will be interact with many other drugs like Cirquil and all, which we are using very commonly. This is methadone. Also, it's famous for its many drug interaction. We are not using this, but and here some of the contraindication. If does not if the patient did not meet the criteria for diagnosis, less than 1 year history of opioid addiction, unable to attend program as required because it needs to be given in the on daily basis. It's not allowed to give patient outside the center. Allergic response, cardiac complication. That's why we select to avoid it, and we use other. I will explain to you in a moment. But in general, methadone efficacy it's improve overall survival, improve retention to treatment, decrease heroin and other drugs, decrease HIV and hepatitis seroconversion, decrease criminal activity, increase social functioning, and improve birth outcome. The second drug is buprenorphine. First, we use buprenorphine with naloxone as a film. Uh, this combination, the purpose to decrease abuse potential for buprenorphine if crashed and injected, because there is risk patient will crash that if it's only buprenorphine and take it. So as I injection to avoid the risk and hazardous, we will give it with antidote. Antidote will be not absorbed if given sublingually, but if it's given injection, it will protect the patient from the harm if misused. So the patient will use the sublingular for withdrawal, and after that, we'll shift him to the long-acting buprenorphine. In our center, we have buprenorphine long-acting. We have different dosage. I'll come in a moment to tell you about the dosage. But before giving it, we need to assure this is the criteria: adult male or female above 18, and now it's approved above 16 recently by FDA. History of opioid overdose, multiple relapse on opioid, and commitment to recovery in outpatient clinic. So we'll give this in outpatient. This is the advantage. We can give it in outpatient clinic because it's long-acting injection. We have the weekly and the monthly. So buprenorphine is semi-synthetic, highly labeled, 25 to 50 times more potent than morphine. It's partial mu agonist and some kappa antagonist. There is no clear clinical significance for this point, and FDA approval to treat opioid dependence. So you can see here buprenorphine and opioid, they are competed for the same receptor, but the affinity for the buprenorphine is higher than morphine. And when they compete, it will block it. And if the patient took morphine, it will not give him any high. So that's why it's used. And even after, because it's long acting, it still will have effect for the 1 week or 1 month according to the injection. Long acting buprenorphine injection, if the patient is the urine drug screen during buprenorphine maintenance treatment is positive for substance other than buprenorphine for treatment time, the patient is candidate for readmission if he's taking other substance. So we will stabilize him again and start the treatment, because it's not allowed to give buprenorphine if he's taking any other substance. So as I mentioned, according to the sublingular dose, if he's taking 2 to 6 or 8, for example, 8 to 10, he will start with 16 mg. If today he took 16 mg, and if he's tomorrow craving, he can take 8 mg as a top up. And next week his dose will be automatically 24. If he took 24 and still he's craving and he needs something, so we will give him another 8, and 32 is the maximum. Then he will be stabilized on 32 every week, and he will come to our clinic, and we will screen him for all, because most of the patients, if they are addicted, they will mix different substances, but we will screen him for all. If he's negative, then he will take his dose 32 milligram, and he will continue on that 32 milligram. But if he's stabilized on 24 and he's okay, with agreement with the physician, he will continue with 24. Then if he's stable for 3, 4, 5 months on a weekly basis, then he is willing with his physician to shift on a monthly. He will be shifted to the equivalent dose. 32 equivalent is 128 monthly. 24 equivalent is 96, and 16 monthly is 64. Last drug is naltrexone, is an opioid antagonist, and naltrexone coming in tablet form and injection. Injection is monthly, but it has side effect. Patients don't like it too much. That's why we keep it for patient who's not tolerating or have side effect with the buprenorphine, or has alcohol withdrawal addiction with opioid, because it is approved for both indication. If we have patient on alcohol plus opioid, he can use naltrexone injection. And this is side effect, and most of the side effect is the injection side. It's 69 compared with placebo. Other most and nausea also, but other is similar to the placebo. So the best addiction management strategy will be both pharmacology and behavioral therapy, not pharmacology alone. So the last question is, the best addiction management strategy will be pharmacology alone. True or false? Please tell me. A or B? Yes, false, because it should be uh, both therapy. And thank you very much. I hope I was on time. The mic is to Dr. Sumaya to introduce the last speaker.